are on. We left after Wallenberg syndrome, and we talked about Horner syndrome when you have that damage to that dorsal longitudinal fasciculus. So now we are in the pons, okay? And the one we're going to talk about here, there's two pontine syndromes we're going to talk about. The first is a medial pontine syndrome. Now, this cross-section that we're showing here is not one you've seen before. This is a cross-section where you're actually looking at the motor nucleus for the abducens nucleus, which is in the lower part of the pons. And so that's, nope, let me get this into this mode. Just so that's this nucleus back in here. Okay, is the abducens nucleus. This is all cerebellum back here, and actually this is your dentate nucleus in the cerebellum, so that's what you're seeing behind it, so don't let that distract you or confuse you. And then that space here, this is all fourth ventricle. This is some choroid plexus in the fourth ventricle. So if you have a medial pontine syndrome, which is typically involves blockage of the paramedian branches of the basilar artery, which last lecture you'll get is on blood supply, and you'll see the basilar artery goes running right up the front of that basilar groove, and there's these little branches that come off of that are called the paramedian branches of that. And so if you have blockage or damage to the basilar artery or those paramedian branches, that's what can cause some of this deficit here. So it supplies this region right here. So what you're going to have is you're going to have contralateral hemiplegia because you have damage to cortical spinal tract fibers. So that you have damage here to the cortical spinal tract fibers running down through the front part of that basilar pons, right? And they're still going down to the medulla before they cross over. So in this case, this lesion is a left-sided lesion. It would cause right hemiparesis, okay? It's also going to cause contralateral loss of position sense and vibration, proprioception, conscious proprioception, okay? Because you've also impacted, let me just get this out of, erase some of the distracting lines here. You've also tend to, in this case, in this lower part of the pons, the medial lemniscus is still in this arrangement here of medial to lateral. It's right there. And so you're damaging the medial lemniscus. And that's coming up. That's crossed over down in the medulla, right? So it's coming up on this side. So this is information coming from the right side of the body. So this is contralateral loss of position sense as it relates to the lesion. So we're talking contralateral to the lesion. So the lesion's on the left, the loss of proprioception's on the right. Ipsilateral lateral rectus paralysis. It's because you're damaging the abducens nerve and nucleus. So the nerve's running out here, you've damaged the nucleus. So you're damaging the nerve on that side. So that's going to cause ipsilateral, left-sided lateral rectus muscle weakness. So if you were looking at this patient, their eye is going to be skewed medial a little bit because their lateral rectus isn't doing the job to counterbalance that. And if you ask them to follow your finger out to the left, it would only go to midline maybe, and then it wouldn't go any further past that because lateral rectus wouldn't be working. Okay? They also might have some paralysis of conjugate gaze towards the side of the lesion. So conjugate gaze, the medial longitudinal fasciculus is essential for making your eyes work together when you're moving them in this coordinated fashion left to right. That's conjugate gaze, okay, because signals are sent through the MLF that you can have the lateral rectus and the medial rectus moving at the same time in opposite eyes at the same amount. And so this is the medial rectus, the medial longitudinal fasciculus is right here. That little structure right there next to the abducens nucleus, that's the medial longitudinal fasciculus. So they're going to have some loss of conjugate gaze, but part of that is also just a weakness in the lateral rectus muscle. But their right eye, the medial rectus may not work that great because it's not getting the signal from the oculomotor nerve going to it because of the MLF is not synced up with the abducens. And so even though the medial rectus is technically okay, it may struggle with that conjugate gaze. You may see that right eye still not do a very good job of crossing midline with the left eye, because the left eye is weak, the lateral rectus, but the right eye is going to stop there too, because of the MLF will be maybe damaged as well. It's not always, you know, I mean, these lesions are not perfect like this. This is like the prototypical perfect lesion if you damaged every part of the pons that is supplied by that paramedian branches. It's normally some variation on this. But if I ask a question on these, I will try to make it pretty darn clear and be pretty stereotypical on these. I'm not going to throw any crazy curveballs on you, okay? So same level here that you're seeing, this is through that same level with the abducens. This is called a lateral pontine syndrome. So we had a lateral medullary syndrome, that Wallenberg syndrome, which is actually the more common. This isn't as common. This is involving what's called the long circumferential branches of the basilar artery. So the basilar artery has these little paramedian branches that go and supply that medial aspect of the pons, but then there's these long branches that go out to supply the backside and lateral part of that pons. So if those get blocked or damaged, you can have a lateral pontine syndrome. So what do you see? You see ataxia, unsteadiness, disequilibrium, and balance problems, because this right here, this big structure here, this is the middle cerebellar peduncle. So this is where you have, you know, motor fibers coming down, sending signals across from the pontine nuclei over to the cerebellum. You're going to damage some of those fibers, and that's going to cause incoordination, okay? And this is going to be, they're going to tend to fall towards the side of the lesion. Anytime you have damage to cerebellum or it's always going to be on the same side. So this is going to be on, this lesion is on the right side in this case, so you're going to have right-sided incoordination. I don't know if it's going to be your legs, arms, all the above, just depends on how big this lesion is and how many fibers are impacted as it's coming across here. You know, this lesion may extend farther out here. Just depends on how many of those you impact. That'll cause loss of function and ataxia, incoordination on the same side. So it's going to cause, really, that would be ipsilateral ataxia, and they tend to fall ipsilaterally to the same side where the lesion is, okay? Unsteadiness and ataxia. They will also maybe have some vertigo, nausea, deafness, because of there's vestibular and cochlear nerves and nuclei in there, okay? And so like you see G here, this is the lateral vestibular nucleus. I don't think they have the cochlear nucleus in here, but remember, these lesions aren't just this little flat lesion. It's extending up and down within that pons. This is near that pontomedullary junction region, and that's where you have the vestibular nuclei and the cochlear nuclei. So depending on the extent of this lesion, you're likely going to impact some type of vestibular and or cochlear nuclei that can cause some deafness, can cause some nausea, vertigo. So, okay? And that would be ipsilateral. It would be on the same side as the lesion. You would have possibly ipsilateral paralysis of facial muscles. That's because this region is very close to where the facial nerve nucleus. Here's the facial nerve. The facial nerve is kind of a weird nerve, and the nucleus, the nerve actually goes back, and it actually goes around the abducens nucleus and then out. So anywhere in this region, you could impact the facial nerve. So you could have some, and that would be ipsilateral. You're damaging the nucleus or the nerve on that same side. You're not damaging the cortical bulbar tracts coming from the brain. You're damaging the actual nucleus and nerve, which is like a lower motor neuron problem essentially in your body. It's a lower motor neuron facial problem. So ipsilateral loss of function in the face, okay? And if you knock out that whole nucleus, it's going to be, you could have both the, well, no, you would have, no, you would. If you actually if you damage the whole nerve and nucleus, you would have upper and lower face being equally impacted on that same side. Versus if it's a upper motor neuron problem, remember you get bilateral connectivity with the upper part of the facial nerve nucleus, and so you, with a cortical bulbar tract problem, you tend to have more lower face weakness than you do upper face weakness. So in this case, if you wipe out the whole nucleus, the upper and lower parts of that nucleus or the whole nerve, it's going to cause the whole side of the face, including the upper face, to be weak. You will have ipsilateral paralysis, possibly of muscles of mastication. The trigeminal motor nucleus can be impacted with this. The trigeminal motor nucleus is in the pons and can be impacted. It'd be ipsilateral, same side, because you're damaging the nerve and the nucleus, in the cranial nerve nucleus. You would also potentially have ipsilateral Horner syndrome, because that DLF, dorsal longitudinal fasciculus, is running somewhere in this region, down in this is all reticular formation, but the DLF is somewhere in there, the dorsal longitudinal fasciculus, so it would cause ipsilateral Horner syndrome. You would also have potentially ipsilateral loss of pain and temperature from the face because of the spinal tract and nucleus of cranial nerve number 5. That's this H and I complex here. You're seeing that spinal tract develop here because it came in. This is a little bit lower in the pons. The trigeminal nerve fibers come in that middle to upper part of the pons. So this is the start of that trigeminal nerve, spinal nucleus of trigeminal nerve, pain and temperature from the same side of the face. Okay, so you're going to have ipsilateral loss of pain and temperature from the face, but you're going to have contralateral loss of pain and temperature from the body because of damage to the spinothalamic tract, okay, or spinal lemniscus, I should say. I shouldn't say it should be the spinal. It should be spinal lemniscus, was the spinothalamic tract till it got to the brainstem. So the spinal lemniscus is this structure here, L, which on this side is this right here. That's your spinal lemniscus. So contralateral, because that came from the opposite side of the body. That all crossed over in the spinal cord and is going up the opposite side now. So that's going to cause contralateral loss. And then same thing as we had with the last lesion, it can impact the MLF. The MLF is this structure sitting right back here, which is going to make it harder for your eyes to work together. So you're going to lose some of that conjugate gaze. You're going to have a hard time tracking past midline, working together because of the MLF being potentially disrupted. So that's that. One more. This one's a little bit simpler. Midbrain, anterior lesions in the midbrain. So this is, you see outline there. Deficits. Because you're damaging a pretty big part here of this is the crus cerebri, all this in the front of the midbrain. That's, again, all those cortical pontine and cortical bulbar tract fibers running down through the front part of that midbrain, okay? Both from the body and the face are all there. You're going to have contralateral hemiparesis, okay? And you also will likely have contralateral, it'll be both the face and the body on the opposite side. This is the one that's a little bit unique because we're way up in the midbrain now. And so this is where if you have a lesion up in that front part of the midbrain, you can get loss of function on the same side. Now you're kind of the point where everything's crossed over and together as you go up into the cerebrum. So the contralateral hemiparesis, both body and face. And then you can have loss of eye movement because you damage the oculomotor nerve. And the one on this particular, this is the oculomotor nerve they're showing. This one right here is coming from the Edinger. They're all coming together as part of the oculomotor nerve. But this is the parasympathetic fibers. This is the motor fibers. So this, depending on the extent of this lesion, you could impact the oculomotor nerve. This is because of damage to or blockage branches of the superior cerebellar artery. Superior cerebellar artery. So that is an anterior midbrain lesion. I think we're done. No, we don't. Crap, sorry. I shouldn't have said anything. We have one more, midbrain tegmental lesion. Tegmentum, middle of the midbrain here. So this is a couple similarities here. One would be loss of eye movement, oculomotor nerve, and that would be ipsilateral, same side, because you're damaging the actual nerve, okay, or impacting the actual nerve. Ipsilateral loss of function on that eye. This is a left-sided, so you have loss of oculomotor function on the left. Contralateral loss of sensation of the face and body. So this is the medial lemniscus here. This is the spinal lemniscus, and your trigeminal lemniscus is in here. Everything's together here. And this is a posterior cerebellar artery lesion. It will impact proprioception from the body, pain and temperature from the face. So once we're up in the midbrain, things start to get more like when you have a lesion, like in your internal capsule, or where everything's getting close together here. So that's because you've damaged the medial lemniscus, the spinal lemniscus, and the trigeminal lemniscus. So contralateral loss. So this is the exception. These midbrain lesions are the exception to the rule of often having that disassociated types of dysfunction of one side of the body that are more pons and medulla. If you're in the pons and medulla, you're likely to have some deficits on one side of the face versus the opposite side of the body. But once you're up in the midbrain, into the internal capsule, corona radiata, up on the cerebrum, everything's going to be contralateral. Does that make sense? You also maybe have some coordination deficits due to damage to this is the superior cerebellar peduncle coming up here a little bit. Actually, no, that's not. That's the medial geniculus, medial geniculate body, sorry. You can't see the superior cerebellar peduncle here. It's down a little bit lower, but it's coming up through this region possibly to go up to the cerebrum. The superior cerebellar peduncle might be more down a little bit lower here in each region here. Those fibers that are coming up from the cerebellum are coming up past that area, and that can cause this lesion can extend into that area and again cause some coordination, ataxia, because you've got superior cerebellar peduncle involved, but it'll also cause some weakness in the upper extremity. It's not real profound. They might have some difficulty flexing their arm because you're damaging the red nucleus, so it'll hang there and it might have more extension in it. And when they move it, they can move it, but it's a little bit more difficult and it looks a little more ataxic in nature because of the red nucleus, but also because you've damaged actual cerebellar fibers that are coming up, and that will cause ipsilateral ataxia and coordination deficits, which could be upper and lower body, depending how many of those superior cerebellar peduncle fibers you hit. Oh, thank God that's over. I present this to you so that you've seen it once. You may see a patient that has these things. I really want you to understand some big picture things on, kind of understanding. You should be able to recognize a few key things that say I might be in a midbrain versus a pons versus a medulla, more medial, more lateral, where those lesions are. And so kind of try to frame some of that if that helps you a little bit. If you're great at, you've got that photographic memory, God bless you, I hate you. But you can just memorize it all, and it's not an issue. So, or photograph, yeah. All right. We are going to move along to, we'll start some cerebrum stuff. File, open, cerebrum. Here we go. Let's get a few minutes of this in before we take a break. You know what? I got to do my little thing here. I got to hit my formatting, transitions. I haven't changed the wide to wide format on this. This is like going old school here. So what happens? Cerebrum. We're up now, up here. We formulate things and integrate things. So perception of our world, voluntary movement, okay? Language. I would love to spend more time understanding language and learning about that. So it's so fascinating. Both verbal and nonverbal. Remember, language is both, and a lot of what we do is nonverbal. Most of what our communication is nonverbal. Spatial relationships, understanding kind of our place in the world spatially, utilizing in visual information to help us make sense of the world, making decisions, in conscious decisions and consciousness, emotions, mind-body interactions, and memory. Those are the big kind of things that happen in the cerebrum a lot. What makes up the cerebrum? You guys know this already. It's the cerebral hemispheres, which includes those basal ganglia structures deep in it. And also the diencephalon, the thalamus, and the hypothalamus, essentially, we're talking about. So the big things out here, the gray and white matter, and then deep inside, we've got the thalamus, hypothalamus, and basal ganglia structures. We're going to talk about the thalamus a little bit more specifically, the diencephalon, but we're going to focus on the thalamus. We're not going to talk about hypothalamus. That was autonomic nervous system. So here's what makes up the diencephalon, but it's really these two, and mostly the thalamus. Functions of the thalamus proper, the big egg-shaped thing. It's got three main functional, primarily regulates flow of information to the cortex, okay? So anything that's coming from the body or coming in from sensory goes through the thalamus, or even sometimes you send signals from your cortex through the thalamus back up to the cortex. And just it's like the secretary. It helps, you know, kind of sift and through and what's most important, what information should we make sure gets to the cortex. Has three main functional groups of nuclei. So you can take that thalamus, which is kind of like a big nucleus itself, and divide it into these functional groups. You have the relay nucleus. This is information from the sensory systems that we've talked about, the basal ganglia, the cerebellum, that all have to talk to the thalamus to go up to the cortex. And those are all located in the ventral tier of the lateral nuclear group. And we'll try to make sense of this kind of topical arrangement here, geography of the thalamus. We have association nuclei. These are primarily for doing there's actually some integration that occurs within the thalamus itself, a sensory integration, also some relationships of storing information about emotional and memory information associated with certain experiences and sensory experiences and tying those together. Those are located in the anterior nuclei and the medial thalamus and also the dorsal tier of the thalamus. Then we have what's called the non-specific areas or nuclei. They're more for just regulating. They play a role in regulation of consciousness, overall arousal and attention. Those are located in the reticular, midline, and intralaminar nuclei. So here is your thalamus here, proper, up on the top there, on the top right, and dividing it into its major groups here. So this structure here is the lamina. The lamina is a layer. It laminates or breaks this thing into some major components. This whole side out here is called the lateral group out here. The lateral group is divided into what's called kind of a dorsal tier back here. It's kind of more towards the top, but it also incorporates this posterior region. So this is the dorsal tier. The kind of bottom part of the thalamus is ventral, you know, because remember the neuraxis is like this. So below, inferior part of it is considered ventral. So this is the ventral tier of the lateral group. This is the dorsal tier of the lateral group. Then we have the medial group over here and the anterior group here, okay? This is kind of a nice picture down below that. So this is the color-coded kind of thing showing you the different regions of the thalamus and the connections they have with your cerebrum in a color-coded format, okay? So the ones that we've talked about so far are mainly these guys here. And the ones we've talked about the most are the VPM and the VPL. This is where you get sensory information coming up from your body and your face. Okay, and you can see that information gets to that primary sensory strip. Okay, and you can see the darker color blue, which is the VPM, is associated with your face, and so you can see that's that darker color region right there, which is associated with your face. These are the interlaminar nuclei. There's some little nuclei that are scattered throughout that lamina. So that's what they mean by the interlaminar nuclei. And then here's your medial geniculate body and your lateral geniculate body sitting off the back of the thalamus in this dorsal tier, but this back portion is also called the pulvinar, okay, which is it's still part of the dorsal tier, but it's the pulvinar is called that back there. And then here's, remember the VL, the information coming up from this is the ventrolateral group. Here, this is axons coming up from the cerebellum. You know, from that superior cerebellar peduncle, those axons are coming up to go to the VL, which then relays that up to the cortex. Okay, and you can see that's going to those motor areas to tell your next signal to come down how to adjust the motor activity. And then here's the VA, which is the basal ganglia, the globus pallidus internus and the substantia nigra reticularis, those output nuclei of the basal ganglia send their axons up to the ventral anterior part of the thalamus, which then project up to the motor planning areas to release, you know, what motor activity you're going to do. Okay, that's that part of that basal ganglia loop. So what do you guys need to know? Those ones, the ones I just pointed out. Okay, and also the medial and lateral geniculate bodies. Those are relay structures for auditory and vision. Hypothalamus, we've already mentioned this. Thirst and hunger mechanisms, homeostasis, it's the master regulator for your autonomic nervous system, reproduction. It plays a little role actually in emotional expression, pleasure, rage, and fear. Has some connections with the amygdala. Hypothalamus is considered kind of still part of the whole limbic system, which includes your cingulate gyrus, your amygdala, your hypothalamus, that are all related to emotional expression and integration. It does play a role in regulation of circadian rhythms, endocrine regulation and growth, metabolism, reproduction. So it does an amazing amount of things, that hypothalamus. We are not going to go into the different nuclei of the hypothalamus and all that, but just realize the hypothalamus can be divided into subcomponents and subparts. We are not going to go into that. But it has a direct connection, some of those, with the pituitary gland. You got an anterior and posterior pituitary gland. Here's the infundibulum, or the stalk. An infundibulum is a little pituitary stalk here that connects it to the hypothalamus. And tomorrow, next week when we take a brain out, we will end up tearing this infundibular stalk because the pituitary gland is sitting in a depression in your skull called the sella turcica, and there's a little membrane that goes over the top of that pituitary gland, and so you can't get it out, you know. But they do surgically get in there somehow and do remove pituitary tumors and so forth, you know. But it's just going to get torn there when we pull off the infundibulum there. So limbic system, hypothalamus, these are the connections. So the hypothalamus is kind of sitting right in the center of your brain and has intimate connections to your limbic system. The hypothalamus influences secretion from the pituitary gland, hormones, and actual neurotransmitters that come right straight from the pituitary gland to influence endocrine production and hormones and growth and those kind of things and reproduction. It has direct connections to the spinal cord. That's through the DLF, the dorsal longitudinal fasciculus, that goes down to communicate with the sympathetic nervous system, T1 to L2, and also the parasympathetic system at S2 to S4. And then it also obviously impacts the brainstem because it's going to talk to the vagus nerve and the oculomotor nerve, any parasympathetic control coming out of the brainstem. The hypothalamus can help to regulate some of that. So that's what we're showing there. The epithalamus, also known as the pineal gland, all you got to know with that is that does play a role in regulation of circadian rhythms. Okay, it releases substances that influence secretions of the pituitary gland, the adrenals, the parathyroids, and the pancreas. Okay, so not going to get into much detail on that. I don't know much about it, so can't get into much detail. This is the pineal body sitting back here. Some of you had that pineal body on your specimens when we looked at brains that first week, that little pineal body. As you age, that pineal body can calcify and become less functional. And that may lead to things like disruptions of your circadian rhythms, less sleep. Sometimes people, as they age, go through periods where they have less sleep because melatonin is produced by the pineal body, which helps with regulation of circadian rhythms and sleep, and you lose some of that function there. And your thalamus would be this region in here, and your hypothalamus here. Your subthalamus would be sitting down in here, a little bit more medial or lateral, I should say. But those are kind of all your structures there that make up technically your diencephalon. Subthalamus, we've already talked about. It plays a role it's part of the basal ganglia circuitry, the subthalamus. So that's it right here on each side. This is the structure here. It's right above. Here's the substantia nigra just below it. The substantia nigra is really the start of the midbrain. So the subthalamus is just here. Hypothalamus would be in this region here. So the subthalamus is just a little bit lower and a little more lateral than the hypothalamus. So we don't see it when we look at a cross section through the middle of the brain here. We're not seeing it because it's a little deeper and it's a little farther out this way, a little more lateral. Helps with regulation of movement and motor output. Let's take a break here before we get into subcortical structures. So we just got finished talking about the diencephalon, which is part of the cerebrum. Now we're moving into what we refer to as subcortical structures. The cortex is that little tiny layer, a few millimeters thick on the top of your cerebrum. We're talking deep to that. So basically the white matter tracks. We do have basal ganglia and diencephalon, which are essentially subcortical structures, but when you talk about subcortical structures, you tend to refer to all the axons, the white matter axons and so forth. This is kind of a really cool way this was dissected out, this brain, but they did it to kind of highlight some of the pathways. So if you look here, this is kind of the corona radiata here coming from the surface of the cerebrum. And then it gets all squeezed down here. This is actually the outside, the lenticular. You're looking at the lateral portion of the putamen here. And these dive down between the globus pallidus and the thalamus to squeeze down to become the internal capsule. Down deeper in here is where the internal capsule is going to begin. So we'll show you some different structures here in a minute. Here's another cool dissection here. But subcortical white matter, these are projection fibers that go from the cortex to the spinal cord, the basal ganglia, the thalamus, and the brainstem. So these are all the axons. There's a couple different types of subcortical white matter axons. One is projection fibers. So projection fibers are projecting from the cortex typically down to or up from the spinal cord. So that works both ways. These axons are going both ways, or the basal ganglia, or the thalamus, or the brainstem. Okay, so those are the ones that are projecting to these different structures. And the internal capsule, right? This is the internal capsule. This dissection has actually removed the basal ganglia structures that are sitting out here. They've removed the lenticular nucleus and the caudate nucleus. And so what we're seeing here is the corona radiata. These are projection fibers, corona radiata, and then internal capsule right here, which has had the lenticular nucleus removed. But just deep to those fibers, if we expose those, would be the thalamus. Okay, so that's kind of with those internal capsules running between those basal ganglia structures and the thalamus. In a frontal view section, that's corona radiata, and then here's internal capsule right here. Here's the thalamus. Here's the lenticular nucleus, putamen, globus pallidus internus and externus right there. Here's a little subthalamic nucleus you can see on each side here. In a horizontal section, what we're going to see here is the projection fibers is mainly this here, which is the internal capsule, anterior and posterior limb of the internal capsule. Remember, we had an external capsule right here, then this little bit of gray matter called the claustrum, then there's an extreme capsule out here. That's just showing those fibers. This is for the motor tracks. These are projection fibers. This is corona radiata here, internal capsule, posterior limb of internal capsule. The motor and sensory pathways that go to your body and face, those are all in the posterior limb of the internal capsule. Okay. Anterior limb has some cognitive relays between your basal ganglia and so forth, and your thalamus that are going through that anterior limb. Another type of white matter is called commissural fibers. These connect homologous areas of the cerebral hemispheres, so from one side to the other. So these are the commissural fibers going across the cerebrum, connecting similar regions on one cerebral hemisphere with the similar regions on the opposite cerebral hemisphere, left and right. Okay. Corpus callosum is our biggest one. That's a big, massive commissural fiber, and it connects most of your frontal and parietal and some occipital lobe functions all from one side to the other. Okay. There's also an anterior and a posterior commissure. Okay, and we've shown you the anterior and posterior commissures previously. The anterior commissure connects your temporal lobes. Remember that little region in the brain? And I don't know if I have a picture coming up here. Yeah, it's kind of got some pictures coming up here. Where you have the optic chiasm, the mammillary bodies, but the anterior commissure is right there too. So and that's going between the two temporal lobes. Then we have association fibers. Association fibers connect cortical regions within one hemisphere. So like on my right hemisphere, I'll have some association fibers that help connect like my motor with my sensory, or my occipital with my parietal areas. Okay, so those allow association of information within a hemisphere. So those are association fibers. So these are kind of your key fibers here. Things in green, those are your commissural fibers. They go from one side to the other. So we have the corpus callosum, and then we have the anterior commissure. So this is the anterior commissure here, the corpus callosum. Here's the anterior commissure right there, connecting the two temporal lobes and the hippocampal regions. And then here's the corpus callosum, which is going throughout the cerebrum. Those are connecting side to side. You know, the red here, that's showing projection fibers. That's what they mean here, is that red. That's internal capsules, projection fibers. But the blues are all association fibers. And we can have both short association fibers and long association fibers. Long association fibers like this one, this is the superior longitudinal fasciculus. Remember, fasciculus is just a bundle or packet of axons. Okay, so this superior longitudinal fasciculus, this is connecting the frontal lobes with the parietal lobes, getting it close to the occipital lobes. And then down here, here's the inferior longitudinal fasciculus, which is connecting various regions within the temporal lobes and getting into the occipital lobe as well. Okay. This right here, well, no, don't worry about it. We'll get there when we get to the language centers. There's a thing called an arcuate fasciculus that connects the language areas. This is called the cingulum. This is a commissural fiber that runs just below, not commissural, association fibers running just below the cingulate gyrus. It's called the cingulum. Commissural fibers. These are little short association fibers. Here they are in a frontal view, and then they have some that you'll see in this horizontal view, sagittal view. They connect just one gyrus with another gyrus. So really short, like, communication between gyruses. Those are called short association fibers. They don't have any real specific names, just called short association fibers, and those are throughout your cerebrum, connecting gyrus with gyrus. All right, now we're moving out. We're into the cortex, just that little few millimeter thick layer there, the cerebral cortex, where the cell bodies are lying, most of them anyway. The cerebral cortex, the outer surface, just several millimeters thick, mostly cell bodies, but it actually has multiple layers of those cell bodies. Those layers are defined by the cytoarchitecture, the type of cell morphology that's in those different layers and the function that those have. So here is a microscopic look at that cortex. Down here, this is where the white matter starts. So these are all the axons, kind of right in this region is the transition. And you have layers 1 through 6. So 6 layers. you'll see some, when we get to layer 5, and we'll talk about that in a second, but you see these larger, really large cell bodies here. These are the large Betz cells. And they're somewhat pyramidal in nature, so this is somewhat the origin of your pyramidal tracts, or some of your cortical spinal tracts are coming from this layer 5. So we'll talk about the ones you really need to worry about here in a second. So layers of the cerebral cortex. Layer 1 is called the molecular layer. It's the most superficial layer. Actually, it contains fewer nerve cell bodies, but lots of dendrites and some axons. So there's lots of dendrites up there interacting with each other in that very surface layer. So some of those cell bodies that are just below it are projecting their dendrites, and they're all getting together up there to communicate. And you do have some axons in there. So it's the exception. Even though it's called the molecular layer, it has the least nuclei in it, or few cell bodies. It's really where the dendrites are interacting. Layer 2 is called the external granular layer. It contains mainly smaller neurons, which establish intracortical connections. So connections within that little, this is where a lot of your short association axons are coming from, intracortical connections. Layer 3 is the extrapyramidal layer. It contains medium-sized neurons that give rise to your association and commissural fibers. So these are the fibers. These are the longer fibers that are going to go from one side of your cerebrum to the other, or they're going to go to larger, more distant regions within one hemisphere. So that's where layer 3 gives rise to those cell bodies that give rise to those axons. Layer 4 is the internal granular layer. It's the site of termination of your afferent fibers from specific thalamic nuclei. So when you are projecting your thalamus from the basal ganglia, from the cerebellum, from your somatosensory system, those are going to terminate up in that into cell bodies or to cells in that layer 4. Layer 5 is the internal pyramidal layer. It is the origin of your projection fibers, so to the extracortical targets. So these are the axons and cells that are going to the basal ganglia, the thalamus, the brainstem, the spinal cord. In the primary motor cortex, the frontal lobe, this layer contains the giant Betz cells, which project into the pyramidal tract, because those are big cells, because they go all the way down. They project all the way down. If you're going to a lower motor neuron in your lumbar spine, that axon actually goes all the way from here, goes down, crosses over, and goes all the way down to that lower motor neuron in your lumbar spine. It takes a big cell body to support that long of an axon going down to that anterior horn cell. Layer 6 is called the multiform layer. It also just contains a combination of association and projection fibers, neurons. Brodmann's numbers, which are the cytoarchitectural map of the cortex. With Brodmann's numbers, there's differentiation in some of the cells on the cortex and even within those layers. And some of that corresponds pretty well to function, okay? So associated with different functions of those regions of your nervous system. These are the ones you need to know. There's 52. You don't need to know all 52, but you need to know these for the sensory areas. So areas 3, 1, and 2 is your primary sensory information. I don't know why it's not 1, 2, 3, but when you look at it, it's like 3, 1, 2 going from anterior to posterior. 5 and 7 is the secondary somatosensory area. 17 is primary vision, 18 secondary, 41 primary auditory, 42 secondary auditory. Then 44 and 45 is Broca's speech area on the left side of the brain, okay? And Wernicke's area, number 22, again, 7-8% of the time is on the left side of a person's brain. There's occasional people that have their speech areas on the right side of the brain. These areas on the right side of the brain, you still have those Brodmann's areas, but they're associated more with nonverbal communication, non-written communication. They're for like understanding more about understanding somebody's facial expressions. So they're, Wernicke's area is understanding language, and that's mostly on the left, like spoken language, but on the right side of your brain, it's more about understanding somebody's facial expressions. Even some of like things like intonation and those kind of things, and their body language and those kind of things. That there's a corresponding area like Wernicke's that's for verbal and written language to understand. It's for body language and facial expressions. And then Broca's area, your ability to actually express yourself facially and body language. Broca's area on the right is for that. Okay, so somebody who's got a stroke on Broca's area on the right, or area 44, 45, they might have lack of facial expression. They might be less demonstrative in their body expressions. Motor areas are a little easier. There's only a couple here we need to know. 4 is the primary motor cortex. 6 and 8 together are premotor and supplementary motor area. And then 9 through 12 is just all called prefrontal. So here is some of those key areas. I don't need to go through all those. You can see those yourself. And we'll go through them here, though, to highlight them a little more specifically. So primary sensory areas in blue here. Here's the 312. Okay, they're really small. They're real small slivers, but they all essentially make up that primary motor strip, sensory strip. Sorry, this is the post-central gyrus. There's a little area here. You don't need to know it, but there's a little area that's for vestibular integration of vestibular information. Area 40. Vision. 17 is prime. We're talking primary here. This is where that information first goes. This is where you recognize the intensity of that stimulus, the characteristics of it, but you haven't made quite sense of what that stimulus means. That's where those things go. So here's vision. Vision is 17. Most of it is on this medial surface, right here on the lips of that sulcus there, the calcarine sulcus, right? This is the cuneus, lingual gyrus down here. But right there, that's the primary vision, is where that goes. And then it does wrap a little bit over to the lateral surface, but not much. Here's auditory. We remember auditory is right on that superior, this is the superior temporal gyrus. We have a middle temporal gyrus and an inferior temporal gyrus, but it's right here on the top, the superior, in the middle of it, right? This is the lateral sulcus, sylvian fissure. Function, for the primary areas of these. So primary somatosensory, this is where you're discriminating shape, size of an object, intensity of the stimulus, texture. The primary auditory is that conscious discrimination of the loudness and pitch. Primary visual, this is the distinguishes intensity of light, shape, size, and location of an object. And then primary vestibular is just discriminating among head positions and head movements. And then we have these secondary areas, and look how much bigger the secondary areas are, because this is where integration happens. This is where you're like taking that primary information and saying, well, what the heck does this mean to me? How am I going to use this information? So you're going to integrate that information, and then you might respond to that information. Then you're going to go use a commercial fiber or an association fiber to go tell your motor system or something to respond to that. So these are larger areas. So you see this 5 and 7 back here is that large parietal association area. This is where you have stereognosis happening, where you're taking that primary sensory information and making sense of it. And then the visual areas are big, large areas. Most of your occipital lobe is all association cortices. Taking that visual image and then going, what does this mean? What do I need to do with this visual information? And then here's your auditory association area here to make sense of the sound, classify the sound, and then you do have some other areas for vision down here for especially, this is for more like visual integration and memory down with the temporal lobe, okay? Somatosensory association, what does it do? Stereognosis and memory of tactile and spatial environment, so you can realize you can use that later on. Visual association, this is where you're getting analysis of motion, color, control of visual fixation, so that you can respond to it. And then auditory association is that classification of sounds. Then we're getting to the primary motor planning areas of the cortex. We've seen all these before. Here's that Broca's area, motor planning. So here's your primary motor strip right there. But then everything in front of that primary motor strip is motor planning, whether it's for the body or whether it's for speech. Okay, and Broca's area here, again, this is primarily on the left side for helping to plan speech, spoken and written. Okay, speech and writing. On the right side, it'd be more for expressing yourself with body language and facial expressions. Remember these do wrap over a little bit onto the medial surface. This is all primarily has to do, at least on the primary motor strip, is lower extremity. Okay, is the leg and the knee kind of hooks over the foot, and also the genitals, okay, for sensory and motor for genitals on that medial surface. Primary motor cortex, voluntary controlled movements, all right? Premotor areas, this is kind of control of trunk and girdle muscles, especially anticipatory and postural adjustments. That supplementary motor area, initiation of movement, planning, bimanual and sequential type movements. Broca's area, motor programming for speech, usually in the left hemisphere only. And then the area analogous to Broca's, planning of nonverbal communication. Emotional gestures, tone of voice, right hemisphere. And then what we collectively just call the association areas. These are kind of in between all those other association areas, those that are specific to motor or sensory association areas. These are kind of general association areas. This is prefrontal. This is 9, 10, and 12 or more in this region here. Okay, there is some limbic. This is this kind of in this infraorbital area. Your orbits, your eyes here. It's kind of, this is called the infraorbital area. Here is more limbic integration. You know, this huge area here is just tying in, you know, somatosensory, these association areas, visual information, memory and temporal areas, so you can do integration there. And it helps you for deciding on a goal, planning how to accomplish that goal, executing the plan. And remember, you have these association fibers that run between these areas to allow you to integrate this information, send it to your frontal lobes, and then help you decide and make plans and interact in a voluntary, meaningful way. And then monitor that. So the parietal temporal association areas are for problem solving, comprehension, communication, spatial relationships. These limbic association areas here are mood, affect, and some memory. This is showing you kind of the process of how you might take a sensory stimulus. You comes in, you process it. It comes into the primary sensory cortex. You process more of it in the sensory association cortex to recognize the type of sensation you experience. Then that goes to the association cortex, which says, hey, now that I've got this new sensory information, what am I going to do about it? Am I going to interpret it? I'm going to, you know, goal selection and planning. Do I need to store this in memory? Is this an important sensory experience I need to store for memory for future reference? And then, do I need to do something about it? Do I need to do a motor task? Do I need to avoid that? Am I trying to manipulate something, accomplish something that requires a motor act? And that's going to be first go to the motor planning areas and then the primary motor cortex to elicit the response. So don't have to have that memorized, just should understand the general flow of how you might respond to a sensory experience and how you might have a motor output based on how it's flowing through the different cortical regions. We're going to spend a few minutes here on limbic system, which is an area that's, again, fascinating. You know, language, emotion, memory, those are just, that's really cool stuff, fun stuff, but we just don't have time to go into that, and it's an area that I'd love to know a little more about. Limbic system components, we keep hearing about it, and that's because it's tied to a lot of different regions in our brain. A lot of our areas of our brain are providing information to this quote-unquote limbic system, which includes your hypothalamus, parts of your thalamus, the anterior and medial nuclei specifically, the limbic cortex, which is your cingulate gyrus, parahippocampal gyrus, and uncus. Those together form your limbic cortex. The hippocampus, which is deep in your temporal lobes, the amygdala, and the basal forebrain. That's supraorbital area or infraorbital area that I showed you back there. That, you know, this area here. Okay, it's also called the basal forebrain, basal bottom part of the forebrain. This is just a kind of a cool picture that shows you some of those key structures here. This is the cingulate gyrus here on each side. This is the other side here. You know, here's your amygdala sitting right down here. There's actually a structure called the fornix, which is generally right in this. It's kind of right in this area. It's right by your lateral ventricles, and this is also called, they're calling it the stria terminalis here, but the fornix is kind of connected to that stria terminalis. Don't worry too much about that. Just understand that a lot of the limbic system structures are associated with this center part of your brain, and also in this kind of infraorbital area here, or basal forebrain area here. It's kind of in that heart of the brain, that circular area here. A lot of things, these are C-shaped kind of structures, and they're connected with each other. And the hippocampus is down here. This is the hippocampal formation down here that also has a little bit of a curvature to it. So these are very centralized structures. They're kind of right deep in the center of your brain and tend to kind of work around the lateral ventricles in that C-shaped kind of format. That's all you really need to know there. What does the limbic system do in general? It, quote unquote, moves us. It's involved with memory, olfaction, visceral control, and emotion. Okay, so it's memory and motivation. Okay, why we do things, what drives us. A lot of it is emotional types of things that drive us, not always logic. We're often more emotional creatures. So limbic system, that gut feeling about making decisions that aren't always based on logic. Storing memory. Olfaction is tightly intertwined with the limbic system, because remember we said olfaction goes directly into your cerebrum and right into the limbic system. It doesn't stop at the thalamus first, so it's a pretty primitive kind of sense. And then the visceral structure, so the ANS response to limbic input. So when you're feeling emotional responses, it's going to alter blood flow to your periphery. It's going to alter your heart rate, your respiratory rate, and those kind of things. It's going to give you those butterflies, you know, your sympathetic nervous system's making your diaphragm quiver a little bit, and those kind of things. So those are visceral connections that your limbic system has. And then emotion, your self-concept and worth, emotional body image, you know, attitudes, social skills, opinions, those kind of things are influenced by this limbic system. Also, I will say, we should say in here, like with viscerals, like response to pain, you know, so you know when you're treating patients who have especially chronic pain, you're going to have to treat their limbic system too. You need to know what drives them, what motivates them, what causes them to have this response to pain. And so some of the, you know, pain modulation stuff we're doing is trying to influence the limbic system, change the limbic system, neuroplasticity. You know, psychological and somatic interactions. So mind-body, it's real. You know, I'd love to ignore it and just say, I wish it would just be nice, like a knee is a knee, and I just want to work on the knee. Don't make me have to work with a person. Just give me, you know, if you want to do that, be an orthopedic surgeon, because then they just put the patient out. You don't have to worry about any of this limbic system stuff. But you know, you guys are PTs, so you have to deal with people that are awake, alert, and come with their baggage. So. You know, stress response can be magnified. Also with individuals' CNS damage, if you take somebody and give them a brain injury, they lose some cortical control over their limbic system structures, those deep structures. And so you walk in and start messing with them, and you start moving their leg or tell them to do something, or get them on a treadmill and work them hard, or do some kind of challenging balance exercise. They may freak out on you, and they may have their blood pressure and heart rate shoot through the roof because their limbic system is under less control, and they perceive you as a threat or whatever. So you got to be careful with some of those things. You know, with stress, long-term stress, you get prolonged cortisol release, which can eventually lead to immune suppression and depression of the immune system, which can cause illness. So this is just showing you the interaction between limbic cortex, your hypothalamus, you know, some of the hormonal and autonomic system influences over the immune system. So yeah, embrace it. Embrace the mind-body stuff with your patients. A little briefly on memory we'll talk about. So types of memory. We have what's called emotional memory, which is really a limbic system function, which we just talked about. That's memory of emotions and feelings. Fear, storing fear, that's more of an amygdala for fear. Structures, also there's some unknown structures for other emotions of how they're stored and where they're stored. It's not like you can just say it's stored here. It's probably a combination of things. Declarative memory, which is the type that we're doing right now, memorizing facts, figures, concepts, locations, those kind of things. That's a cerebral cortex and a hippocampal function, okay? Then we have procedural memory. Procedural memory, it's like procedure. You're memorizing a procedure or an action or a movement, a sequence of actions or movements. This is skilled movements and habits. So this is motor learning, essentially, procedural learning and motor learning. We're doing a lot of that in PT, right? So that's what we're doing a lot with our patients. That's more frontal cortex, thalamus, basal ganglia. I would also add cerebellum in there. It's really critical for long-term procedural learning. So you can actually have patients that have difficulty with some areas of learning. Like you can have somebody with Alzheimer's or dementia who has difficulty with declarative memory, doesn't know your name every day you walk in, but if you get in and do 30 sit-to-stands with them every day, if their basal ganglia is still functioning okay and their cerebellum is still functioning okay, you can still get good motor learning. It just takes repetition. They may not be able to do your home program unless they have a caregiver who can help them do that. But if you go in every day and work on gait and balance, you can still get good improvements. It used to be that they would, sometimes you get denied payment for somebody with Alzheimer's because there's expectation they weren't going to benefit from the therapy because they can't remember. But that's the declarative part of it. It's the motor part of it that you care about a lot of times. We're going to talk about communication now, another area that's just really interesting. So you can read this cartoon here. This is the way. This is more of a communication between me and my wife. This is. I'd love to. Yeah, exactly. I'm not admitting to it. Actually, that's probably I'm the dog. So yeah. I'll just hear is Kurt, Kurt, Kurt. I do feel least guilty about it for a few minutes, and when I'm zoning out and not listening. So. I'm trying to be really good about that. First few minutes when I get home from work is like just phone over here, sit down, look in the eyes, all that. Yes. Sometimes it still doesn't work sometimes. It's still like drifting off. I want to go for a bike ride. I want to. So, hey, I'm a guy. What can I say? All right, cerebral areas of communication. 95% is left hemisphere for verbal and written communication. So you should probably add on there verbal, written. We have what's called Wernicke's area, which is for comprehension of language, both written and verbal. Broca's area, which provides instruction for language output. That's spoken or written language output. And then the corresponding right hemisphere has those same things for nonverbal communication. If you are left-handed, your chances of having your speech centers on the right side is a little higher, not much, but if you're left-handed, it's not like automatically your speech centers are on the right. And when you talk about cerebral dominance, are you left-brained or right-brained? You're typically talking about where your language center is, 97-8% of us are left hemisphere dominant with our speech centers. Somebody who is left-handed, or people that are left-handed, it might be closer to 92% versus 98% or something like that. I don't know the exact numbers, but there's a chance though that your patient. So if you're treating a patient who's got a stroke who's left-handed, and their stroke's on the right, and they happen to also have aphasia, and some, you might go, okay, maybe they are one of those right-sided language people, Which would be a bummer for them, because then you wipe out their dominant hand, plus they get, aphasia at the same time. So here is kind of the process of what happens with communication. This is verbal communication, okay? So somebody's talking to you. Comes into your primary auditory cortex, number 1 here in the step. It goes to your auditory association area, and it says, oh, this is somebody talking to me. This is speech. I recognize this as speech. It goes back to Wernicke's area right here, and that actually makes sense of what that speech says. These are words that I'm hearing, and this is the meaning of those words, putting them together for you, okay? If you are then going to respond in a conversational type manner, if you don't, that's where it ends. You heard it, you understood it. But if you're going to then respond back to the person, you will send a signal to Broca's area via, this is called the
arcuate, sorry, fasciculus. This is the arcuate fasciculus. That's a association fiber, it's a sort of long association fiber, kind of a medium length association fiber that runs from here. That goes to the Broca's area, and that's where you formulate the plan based on what I understood this person said. I'm going to plan to say these words in this sequence together to make meaning, to send that back, and then you send it to the primary motor strip here in the face and tongue mouth region to then send it down through the cortical bulbar tracts to your cranial nerves to make the sounds and formulate the words in a meaningful way. Does that make sense? So that is how that works. And I think on Monday we'll get into damage to that and look at different aphasias and show you some videos of different types of aphasias, we call that. Spatial awareness, this is mainly on the right side of your brain area corresponding to Wernicke's. This is where you get kind of this body schema, awareness of your own body in space and kind of understanding that and how it relates to the surroundings, you know. And then spatial orientation of the external world. So your patients that have right-sided damage to their cerebral hemispheres, often like if it's a stroke or something, they might sit way over to one side and they're not sure about where they orient themselves to midline and alignment and those kind of things. Is that it for today? We're not going to do the lumbering. So we're going to do this today. We are going to do one case, and then we'll still be done early today, okay? Let me pause this.